Hello, everyone. Welcome to the 11th episode of the Dr. Suit podcast, where we connect medicine and business and technology. This topic today is very dear to my heart, and I've been really passionate about it to really interview Dr. Anurag Mairal. So, today we're going to talk about global biodesign and innovation, how we really reimagine healthcare of the future with Dr. Anurag Mairal. To introduce you, Dr. Anurag Mairal is an adjunct professor of medicine and director of global outreach programs at the Stanford Center for Biodesign. He also serves as faculty fellow and lead for technology, innovation, and impact at the Center of Innovation and Global Health. Dr. Mairal focuses on applying the biodesign process to resource constrained settings and mentoring students and faculty in addressing global healthcare needs. Besides this, he's also founding chair of the Biomedical Engineering and Asia Pacific Alliance, which really focuses on innovation, design, and entrepreneurship, promoting medtech innovation across Asia Pacific region. He was a professor in the University of Cape Town as well, and he has a lot of tremendous industry experience, holding many leadership positions in Path, Johnson's and Johnson's, Orbis Medical, driving innovation, medtech, and digital interventions in healthcare sectors globally. His works has actually advanced product development, manufacturing, and commercialization in US, India, China, and emerging markets across the globe. Dr. Mairal holds a PhD degree in chemical engineering from the University of Colorado, an MBA from UC Berkeley, and degrees in chemical engineering from IIT Bombay and NIT Raipur. He is also mentor, author, and inventor with over 30 publications and 7 patents. Thank you for joining this podcast, Dr. Mairal. It's really an honor to interview you today.
Well, thanks for having me, Mohit. I'm looking forward to the conversation.
Yeah. So before we get started, I really want to understand, Dr. Mairal, your personal journey. You have a background in chemical engineering, but now you're a recognized leader in global health and innovation. In fact, you also met PM Modi recently. What really inspired you to really pivot towards medical innovation from chemical engineering itself?
Yeah, that's a great question. If you had asked me when I was doing my undergrad that I would be doing this, I would not have been able to guess that. But chemical engineering, I call it the Swiss Army knife of engineering. It gives you exposure to lots of different things, fluid dynamics to thermodynamics to chemical processes. It's just a range of topics. So it really prepared me well for a number of different sort of areas of engineering that I did my work in. First, during my master's at IIT Bombay, and then during my PhD. And in fact, I didn't quite like biology as a subject when I was growing up in India because I found it to be rote learning. Little did
Yeah.
I know how interesting biology can be. Biology is basically it's physics, engineering, chemistry all rolled into one. It's one of the most complex systems, the human body, and there's so much that you can do if you apply other disciplines to that field. So my during my PhD advisor actually exposed me to medical devices. He was working on a blood oxygenator. My own work was in membrane technology, which was more on water treatment, but the similar kind of membranes are used for but blood filtration, microfiltration, ultrafiltration, and for oxygenation as well, similar processes. So that kind of really got me started. But then my first job after my two postdoctoral fellowships was in a biotech company using
Okay.
membranes to separate proteins from liquid streams. And so that really got me into life sciences. And after my MBA at Berkeley, I had an opportunity to interview with Johnson, and they invited me to join their cardiovascular business. And I was just fascinated by what they were doing, and I that was sort of my full transition to medtech, and I have not looked back since.
Thank you for this very wonderful answer. But what I've realized is driving change through technology, specifically in the healthcare sector, is very challenging. I've seen several startups still at a stage that has not scaled. So what really drove you to take that challenge, to transform it using technology?
Yeah, that's a great question. So, my work at this biotech company where I was doing membrane technology for protein separations, things like that. I was approaching it more from a PhD postdoc perspective, developing new technologies. But very quickly, I realized that the markets actually need far more than that. Technology is just part of the solution; it's not the entire solution. And in
Hmm.
fact, when I started doing my MBA at Berkeley, that I realized that there's a whole world of understanding the customer, understanding business models, pricing, that basically makes a technology a really relevant and useful solution for the problem that we are trying to solve. So it kind of gave me a 360-degree view of how technology must be viewed not from a technologist's point of view alone, but from a problem solver's perspective. And when I actually after J&J stint, when Stanford recruited me to join the biodesign program, that's when I realized that technology must be needs driven. I had the sense of it, but Stanford Biodesign exposed me to the structured way of approaching it, and that's when sort of the loop closed, starting a journey of a technology innovator who just thought from technical point of view, technology point of view, to getting business backgrounds, like you need all of the other business elements to it to make it successful, to ultimately start coming to the backwards, coming to the unmet need, and how critical that was. So it's been a remarkable sort of journey of education for me, not just in a school setting or a college setting, but also through the industry and through my academic stint.
Yeah, that makes a lot of sense. As you mentioned, technology should be needs driven, not just build new technologies. That's a wonderful conversation we'll have at a later stage. So the next question I have is in terms of the Stanford Biodesign, right? You joined the Stanford Biodesign. This model has really been a pioneer in actually establishing the concept of biodesign across the globe. The program has formed multiple alliances across Asia, Pacific, India, as well as parts of Africa. And many of these models are currently being used in the US as well. Let's name it UCLA, Mount Sinai, and also Montefiore system. But somehow you have not trademarked the methodology, you have not trademarked the interventions, you have not trademarked the resources. What is your perspective towards that?
They often say that any initiative or any movement actually has a mark of its founders or its early proponents on it, and that really shapes where it goes. And OpenAI is a good example. There are many movements like that. In fact, internet was built that way. Biodesign story is very similar. The two co-founders of Biodesign, the real pioneers, my role models, Dr. Paul Yock and Dr. Josh McCower. Dr. Paul Yock was a founding director, and Josh McCower was a co-founder and now director of Biodesign Program. These two basically, right from the get-go, said this must be a framework that has to be accessible to everybody. It must be made available to everybody. And our job, they said, was to train minds in this methodology. And if we can't train every single mind, then we should make this available to everybody else who can. So that was the mindset they started with. And honestly, all of us, faculty members who are part of biodesign, basically have just been trained and steeped in that. So when we started off global program, the first global program, in fact, that's when I joined Stanford. Stanford had been, this is 2007, Stanford had been around for, biodesign had been around for 2000, for 7 years now, starting in 2000. And it had been already fairly successful at Stanford. Number of technologies had come out of it. Number of people had been trained who had done amazing things. And we said, well, it'll be interesting to see how this would apply to global problems. And we knew from our biodesign sort of that philosophy that it has to be on the ground needs finding. So we needed people trained who are in those settings. So the first country we chose was India, the hardest country to do this actually at that time, but remarkably good choice as we would find out later. And we said, how do we do this? Do we sort of just train folks from remotely in the US and then have them go do innovation in India? That didn't quite make sense. So we basically brought innovators from India. We trained them at Stanford, and then we sent them back and then had them do that work in India, needs finding, and then innovation around that. And that really worked very, very well. And even then, our thought was, well, what we really want to do is we want to train these fellows, but we ultimately want to give the methodology to our partners, AIMS and ID Delhi, supported by
Hmm.
Department of Biotechnology, Indian government. And we really wanted to give the methodology to them because we didn't have the bandwidth, we didn't have the resources to sort of continue to do this in perpetuity. You're just bringing 4 fellows every year to Stanford and doing this was pretty significant amount of work for us. So our goal was to train those innovation programs, and I think that really worked because India program expanded. The first program became larger program after we handed the program back to them. And India actually ended up founding 10 more programs. So there are now 11
Oh,
official
wow.
programs by Government of India. And
Wow.
that methodology has just taken root. And it aligns with the mission that we had. This is exactly what we wanted. And guess what happened? We succeeded in India, and then Singapore approached us, and then Japan approached us, and then Taiwan approached us. So all of these countries started to say, "Well, we want to learn this methodology," and basically we made a little bit of a tweak in our methodology where we started training faculty members. So we created a program called Global Faculty in Training with the same idea that we wanted to teach them how to fish rather than giving them the fish. And the last point I'll make about it is that we do care about biodesign methodology. We do want it to be done right, because if you just sort of paying lip service to it and you're not being rigorous, then you are really doing disservice to the health technology innovation that you would do and the patients that you would serve. So the programs that we get extensively involved with, we insist on a certain amount of rigor. We spend a lot of our time, energy. That's the only degree of control that we apply if you're formally involved. But methodology is open to everybody. The book is available to everybody. You read the book. We have made YouTube videos. We have made that available. We have made curriculum available. And people can create their own innovation programs, and they do. There are more than 50 programs in 6 continents now. We don't have a
Wow.
program in Antarctica, but most of those programs we don't directly sort of train or work with. We inspire them, we support them, but there are a handful of those programs that we actively work with, and that's when we put a lot more emphasis on the rigor. And our hope is others will learn from what they see, and they will do it as rigorously as some of the programs that we are working with are.
Definitely, that's a remarkable achievement of the Stanford Biodesign program on its own. But what I've realized is when you're translating the knowledge, right, from one place to another place, something is lost, right? Um, I was obviously scrolling through multiple
Something is
pages of all
gained
the
too, by the way.
something
Something
is
is
gained
gained
through.
as well. Something
Yeah.
is lost, yes, and lost in translation, lost in cultural sort of translation, but something is gained as well, and I'll talk about that. But please continue your question. Sorry.
And and the question is, okay, I'll read the methodology today, right? But somehow there's something that's lacking that I won't be able to apply that methodology. So what does Stanford do uniquely that no other program is actually able to perform to that task? For instance, there's so many programs in the US as of now, right? Why majority of the startups are coming from Stanford, not other programs?
Yeah, it's an irony actually, because we our founding directors Paul and Josh both say we are in the business of training minds. We are not in the business of creating startups, and
Hmm.
yet a lot of startups come out of the program, and that's because we know that once you're trained an innovator appropriately, really rigorously, that innovator will it's a gift that will keep on giving. They'll keep on finding problems because it's problem needs driven, right? So you see a problem and you want to solve it. So, but you want to understand the problem deeply, and there are lots and lots of healthcare problems out there. So you just created basically a change agent in that innovator, and so I think that extreme focus on the innovator and making sure that innovator is very highly trained, and so that's one piece of it. The second piece of it, there is there is a of course there we have biodesign faculty and my fellow professors at biodesign who teach this methodology both in the US and globally. But there are hundreds of amazing medtech professionals, senior leaders who give a lot of their time to biodesign community. And
Hmm.
they really like the way we approach the innovation methodology, the openness that we have, and they find that their time spent with our innovators, enabling them, guiding them, mentoring them, is well worth it, and there's an ROI for them in terms of the satisfaction they get. They don't get any paid from us. They all they get is this joy of shaping these minds, and that's a second piece. So the first one is extreme focus on the innovator. Second is really high degree of support from the biodesign or medical technology innovation community broadly. And it's a
Hmm.
global community now. Any part of the
Yeah,
world you go to, Latin America, Africa, Asia Pacific, Australia, Europe, you'll find biodesign community, medical device innovation community that's steeped in biodesign methodology. And so you find this like-minded individuals, people who have done it before. So that's a second piece of success. And third is our willingness to share, right?
hmm.
Being open about it rather than being controlled. We don't take IP. In fact, the India program that we built, we did something that Stanford had not done before. We had a three-way agreement between IIT Delhi, Ames, Delhi, and Stanford waived all technology IP rights coming out of that program for those 8 years that we trained. We didn't
The
take
best
any
of
IP
both,
from it.
the best of both worlds. Ames,
Yeah,
IIT, and Stanford,
yeah,
everything
and we
combined.
didn't take
Wow.
any. Yeah, we didn't claim any IP from it. All the IP resided with Ames and IIT Delhi. That what it did was it enabled these innovators to license that quickly and sort of
Hmm.
create businesses around their technologies, not be burdened with a lot of processes with two different countries and so on. So that's kind of the mindset. That's a third piece of why Stanford Biodesign methodology has been so successful around the world.
Beautiful, beautiful. So, in your own words, could you really describe to our audience? I mean, what is biodesign? I mean, I know it's from what I know, it is a process-driven application, scientific way of actually finding a problem and solving it. But according to you, what it is, and could this be applicable in every industry as well?
Yeah, great question. In fact, I'm applying this methodology in another setting, and I'll talk about that in a minute. So for me, biodesign is basically applying design thinking to healthcare, and it's really keeping the unmet need at the center of it, being
Hmm.
very rigorous about finding that unmet need and understanding it really, really well, and only then starting to think about the solution. So that's what biodesign framework really is in my mind. And as you hinted at in your question, yes, that methodology, that framework, that mindset can be applied to every single problem. I actually host a number of delegations from different fields at Stanford Biodesign who are looking to learn this methodology, this innovation framework. Automotive industry, other folks that come from India, really building a broader ecosystem for us in places like
Hmm.
India, so globally. And they find that framework very interesting from their perspective. I'm actually applying it right now. I'm part of a nonprofit organization called Seva International, which works on local underserved communities. So I'm at the Bay Area president. There are 48 chapters around the U.S. and they're all serving local underserved communities, migrant workers, a
Okay.
homeless population, and folks like that. And what I'm doing is there's a high school student part of the program of this organization who basically a program called Design to Lead, where I
Hmm.
teach 250, 300 students every year this by design methodology, but they apply it for unmet needs in the community in 5 different areas: disaster relief, food security, health inequity, educational inequity, and distressed families. So, and remarkably, these students, high school students, have been able to learn the framework, they've been able to apply, and they've been able to solve many of these problems, come up with more nonprofits and more sort of community-based solutions to these problems. Most importantly, though, learning from biodesign program,
Yeah.
my focus is on developing these people. These kids are going to go on to college and beyond, but the framework will remain in their mind, and it's going to be a needs-driven or problem-driven solution.
So, for example, you did mention about disaster relief or food security. In fact, we have our prior episodes were about disaster relief and food relief in places like Rwanda and places of Africa. How do you really apply the biodesign methodology? If you can probably share an example, for example, with disaster relief.
Yeah. So I just want to be clear that we don't do this at Stanford Biodesign. Stanford
Yeah, no, I
Biodesign
know
is
that. I
all
know
healthcare innovation.
that.
Yeah. So I think so I'll give you an example of Houston, which was going through some floods in the prior years, and there are teams that actually worked on unmet needs in their community around flood disaster, and how do you sort of do acute response to the families that are being affected by floods. So Orissa is but you can also apply this in war situations. So
Yeah.
we've talked about applying it in places like Gaza and other places where like Syria and so on, where it's far more emergent needs. So you can apply this methodology in a lot of different settings.
Makes sense. Wonderful. It's a truly scientific way, and it makes sense, right? Because even in other
Yeah,
industries, you're constantly hunting for the customer need, right? And let's
yeah,
say fashion or anything else.
yeah,
Wow,
indeed.
beautiful. So, when we really talk about an MVP in healthcare in general, which is often the minimum viable product. It is often unique. It's not like other industries. For instance, if I had to build a app to maybe sell sell shoes, I can just create one web page. But what is an MVP in healthcare exactly? And from what I know is it is equivalent to the full manufacturing unit, which is the prototype. So according to you, what is an MVP and how do we really build an MVP because many people are often spending significant resources, time, and brains on building the MVP.
Yeah, I think the term MVP, minimum viable product, it really depends on what part of healthcare spectrum is the solution in. Healthcare delivery versus diagnostics versus digital health solution, AI-enabled care delivery, for example, or devices, drugs or vaccines. In each case, MVP is different. For example, the vaccines during COVID-19, the vaccines that we got was an MVP. It was released under humanitarian use exemption. It didn't go through a full regulatory pathway because of the emergency that we were dealing with, and that was the MVP, and that was the final product as well, in some ways. Often when you're talking about medical devices, for example, MVPs that goes through a bunch of prototyping, and only after it has gone through sufficient human testing can that product become an MVP. So,
Hmm.
because a product really means that it's solving a problem, right? And unless it actually addresses a disease or a condition for a human being, it's not a product. It's still a prototype. So that's how I define it. In digital health, it could be a much simpler thing. So, for example, an MVP for Viz AI, which is an AI-enabled healthcare care pathway solution. MVP there is really finding patients using image analysis, putting an AI algorithm on it, and even if you are catching one patient that was not being caught, it could be an MVP as long as an healthcare institution is willing to deploy that, right? Whereas for a drug molecule, you need far more development investments before it can become an MVP. So it really depends. But my view is that it's unless it is solving the problem in its most basic way, it's not a MVP yet. And last thing I'll say, this is more biodesign framework. In biodesign framework, you have an unmet need statement, which you basically write down your unmet need as a need statement, which is the problem, the population, the outcome, and then you have criteria, the must-have and good to have criteria. MVP for me is a prototype that addresses the problem stated in the unmet need statement, but also meets the must-have criteria. Doesn't have to
Makes
meet the
sense.
nice to have or good to have criteria. As long as it meets the must-have criteria, it's now a minimum viable product.
Makes sense. Makes sense. So my perspective about AI as well, right? From what I've realized is if we have to really address value-based care, the primary thing really starts from the bottom of the pyramid, which is the primary care. Apart from that, I've also realized that AI can be established in mostly administrative roles, such as revenue management, completing notes, then converting scripts to HPIs, what we frame that in EMRs. But has there been any beneficial factor of AI in patient-driven care itself? Because what I realized is there are only around 400 FDA-approved algorithms about AI, and then validating these AI algorithms across different healthcare settings is very difficult. So why should investors really focus on the patient-driven aspect of AI? Why should we really focus on the patient aspect of AI? Or why should Stanford also focus on the patient aspect of AI when we can reduce the cost directly by improving administration efficiency?
Sure. Yeah, administration efficiency is a big part of healthcare expense in the US, and that's absolutely the lowest hanging fruit for AI. Actually, I just tweeted about this today. The healthcare institutions were basically finding out that AI solutions that they had, the algorithms they had, they actually had to had to hire or deploy a really expensive human resource to use that AI tool effectively in patient care. And it reminds me of what Jensen Huang, founder of or CEO of NVIDIA, said. AI will not take human jobs, but human beings who use AI will take jobs of human beings who don't use AI. So that just a sidebar. But you're absolutely right. I mean, look, AI is a tool. I think
Hmm.
anybody who thinks of AI as something other than a tool is really not seeing it right. I mean, you go back and look at digital health solutions like patient management information systems basically, or EMR systems, electronic medical record systems, or other tools that came before. And right now, frankly, in the US setting, where it creates most value is in the processes, in the healthcare systems, which has a lot of inefficiency. 18% of GDP that we spend on healthcare, we don't do it we don't spend that money on interventions. A lot of that money goes into these other things that AI can potentially help reduce, and we must reduce the cost. Actually, it's ridiculous amount of GDP that we spend on it. But if you go to Africa, where you don't have a last mile clinician that can see a patient and determine whether this patient who is having a postpartum hemorrhage should be rushed to a
Hmm.
surgical center 100 kilometers away, there an AI solution has a very different role to play. It's not no more about the cost there. It is a little bit about the cost, but it's far more about bringing access to care to that last mile. And AI
Makes
there can
sense.
play a really significant role.
Makes
So
sense.
you really have to look at the setting. You have to look at what the unmet needs are. You have to look at what is the greatest value for AI as a tool in that setting, and use it for that. It's as simple as that.
So it's more about process-driven approach and integration of AI to really reduce the inefficiency, whether it comes to time to diagnosis, time to intervention, or also time to reduced cost, I mean, drive value-based care itself. As of patient care, I know Cure AI, which is another phenomenal radiology-based company, has done really well in improving outcomes of patients. Apart from the radiology aspect of AI, which is being used, it's currently being used mostly in many places across the world. Have we seen AI really being used in other aspects of patient care?
Yeah, they are, but not as effectively as it could be.
Hmm.
But there are some remarkable interventions where, for example, in ophthalmology. I mean, there's a company in India called Forus Health, which has got a fundus camera, which is a hardware, a really innovative fundus camera, deployed in remote settings across various states, including Andhra Pradesh. And all that data, the fundus images, camera images, actually get uploaded to the cloud, and AI algorithms that Fortis Health has developed assesses the ophthalmological conditions of the patient in this remote setting, and moves that patient through the care pathway through appropriate recommendation, whether that patient needs to be sent to a secondary or tertiary care setting, and there they have a partnership with
Makes
a
sense.
private sector healthcare delivery organization, or the patient should just stay in the community and maybe needs maybe a vision correction or something simple like that. So I think there are already patient care focused solutions that are already being effective. Another example is TriCog, which has already screened or diagnosed um, millions of patients for cardiovascular disease. So there are a number of examples like that. You just talked about Cure AI, which has moved a number of patients from the communities into the care pathway for stroke and for TB and other conditions.
So you need to push the patients from the bottom to the care pathway so they go somewhere.
Yeah, I mean, look, honestly, the healthcare systems that we have right now, I don't call them healthcare systems. They are really sick care systems. We
Yeah,
engage with the system when we are sick.
yeah.
And so a lot of these patients don't have access to, in remote settings, access to healthcare. They have to go to these secondary or tertiary care settings to get the adequate care. And if you can flip that pyramid and bring care closer to the communities, I think that's a really good use case for AI, which is what
Hmm.
these companies are doing.
Yeah, yeah. You have shared a lot of deeper insights into AI. 10 minutes ago, I was just clouded with AI, you know. One question I have is, you have worked in many countries, India, US, and multiple countries. Now, when we walk through India, there are tons of problems we see, tons of solutions we see that could be low cost, low effective. And in fact, Path is doing a phenomenal job in actually providing low cost care through technology to the deepest rural aspects of India. But why many of these solutions have not been transferred to the West? There was a concept that was trending back in the days called reverse bioinnovation, from what I'm aware. I don't know what it is. I really want to have more insights into it. From what I know, only is some hypothermic blankets that were being used in Nepal were transferred to the technology was transferred to UK, and they used it to have neonatal hypothermia in order whenever they're going under some unstable condition. But what is reverse bioinnovation, and why we haven't transferred a lot of technology from emerging countries to Western countries?
Well, reverse innovation, I don't quite like the term. Actually, what I prefer is there's a term that I was playing with about a decade back called reciprocal innovation. But it's really, it's what you're really talking about is learning from each other.
Yeah.
There are things that you can learn from each of these settings. The fact that we spend 18% of our GDP on healthcare and our life expectancy is going down isn't something to be very proud of. So clearly, we have some things to learn, and there are a lot of things that we can't do in the U.S. because of the way our healthcare systems are set up, because of the constraints that we have put on ourselves that a lot of other countries, Africa, India, could do. That we should learn from. In fact, when I was at J&J, there was an R&D center that was created in Mumbai, India, the first of its kind by J&J anywhere in the world, actually first of its kind by any medtech company in the world at that time. This 22 years back. And they came up with a really remarkable blood glucose monitoring device that was simple, easy to use, low cost, robust. It wasn't very fancy in terms of how much data it could store and so on, but it really was very sharply focused on the unmet needs of the patients in India, and it became very successful in emerging markets for J&J. Um, and then, lo and behold, some of the doctors from the US actually are visiting these places and say, my patients back in India, that some of these doctors from southern United States actually could benefit from this. So that device was then launched with a different branding and different colors and so on in the US with a little more packaging. And that was a hot selling product. So that's clearly there was something innovative about that whole thing that was
Mm,
suitable, appropriate for the settings here. So, and that is the lesson. Lesson is not just about bringing innovation as it is from here to there or there to here as is. You have to really think about the unmet need, the cultural setting, the healthcare system context, the constraints, the way economics works, the way the training is. A lot of those things have to be taken into account when a technology or solution can be translated. So I think the underlying technology can be translated, but how it becomes a solution in one setting and taking it from that setting to another setting must take that into account. So there is an opportunity to learn. There are lessons to be learned, but I wouldn't just take just the way we used to do this in the past. We would take a technology developed here, we would defeature it, we would parachute it into a new setting. That didn't really work. Otherwise, we would have addressed a lot of disease burden in many of these countries. It didn't work
Yeah.
because we were not looking at the context appropriately. It's the same thing about the reverse innovation too.
So where do you see India in the next 10 years in the $4 trillion economy that's about to become? Where do you see healthcare really progressing? What is the next 10 years of India healthcare system looking like?
There's something remarkable going on in India right now. I've been engaged with India. I mean, I grew up in India, but I left the country 32 years back. But last 17 years through Stanford India Biodesign program, and after that, the phase two of our work, which is in supporting innovators coming out of these innovation programs and helping them translate their technology. I've been fortunate to have a front row seat to seeing what's happening. Last one decade, there are some remarkable changes that are happening in the healthcare system. There is now insurance program that's world's largest, Ayushman Bharat, that covers a third of the country, 500 million people.
Wow.
There's a digital public infrastructure that's been created called UPI, world's biggest such infrastructure, that basically sees more digital transactions than the rest of the major countries combined. And on that platform, on that backbone, is now riding what is called Ayushman Bharat Digital Mission. They're creating an Aadhaar card, which is a health account for all Indians. There is, healthcare delivery, last mile delivery through ASHA workers, A&M, being enabled through new technology. There's lots of innovation going on. India is now third or fourth largest innovation ecosystem around healthcare.
Okay.
Most folks don't realize it. So there's some
Okay.
really remarkable things going on. And what I see happening in India, if everything goes well for India, and I hope it does, because it has lessons for us here in the US. It has lessons for the 5 billion people of Global South. So I hope India succeeds in it because the humanity will benefit from it. I think of the healthcare pyramid, which is mostly tertiary care at the top, where most of the dollars, most of the infrastructure, most of the technologies, most of the human resources are, versus primary care, which is where most of the people are. I see a flipping of the investment, the resources, the training, the technology, where a lot more patients actually get access to it at home, near home, in their community. And interestingly, counterintuitively, it actually saves the system a lot of money.
Yeah.
So that only the right patients who really need to go to tertiary care setting at the right time actually end up, and we saw this during COVID, by the way. During COVID, India actually deployed these COVID care centers across the country. For a country of $1.4 billion with such a 1.4 billion people with such a anemic healthcare system that they had, they should have seen a lot more deaths, a lot more disability, but they were able to deal with it because they created these local centers across India. And I think they realized that, and they enabled these ASHA workers and other healthcare workers through oxygen, through oxygen concentrators, through pulse oximeters, and so many of these tools. They realized that they can actually deliver care in the last mile in a much more effective way and reduce cost. And that's that flipping of the healthcare pyramid, which is a major passion area of mine. I see that happening in India, and if they succeed in doing that, I think the cost of care. Look, India spends 2.5% of its GDP on healthcare. We spend
Yeah.
80%. Europe spends 10%. There's no way India can ever get to 10% of its GDP. It has got
Correct.
roads to build, schools to build, houses to build, and so on. They will never be able to spend that kind of money on healthcare. The only way they can actually provide care to all of their people is by bending the cost outcome curve. And the only way to do it is through technology innovation. and that's what they're trying to
Yeah.
do.
So what I've realized is also 2% of the cost spent on preventive care really saves 98% of the healthcare cost. That's one thing. The second thing, in terms of the culture of India, right? Comparing the culture of US. So in India, there are two factors. Number one, people only go to doctors when they need them. That's what I've realized in general. There's not a strong emphasis on preventive care. That I do understand completely. And the second thing is 65 to 75% is out of pocket expenses. Comparing to the US now, for instance, people are having their annual mammograms, people are having their annual pap smears. Screening programs are really robust here. So how do you see how can private players really benefit from India as a healthcare ecosystem? I do understand that majority of the money currently is coming from tertiary care, but how can private players make the primary care more profitable as well, provided people only go to uh, primary care when they need them or doctors when they need them?
Yeah, great question. I actually was in India just I came back 4 days back, and part of my trip was to take Stanford's Night Hennessy scholars through an India trip. I do that every year. This year, they met, amongst other people, Dr. Devi Shetty, who's a dear friend of mine and a great thought, thinker and thought leader in healthcare. And many of his ideas resonate with me, and I think in similar ways and some of those things. What he is doing through his health system, Narayan Health, he's creating an integrated health system where he's got tertiary care and he's offering all kinds of disease focused or therapy area focused care, tertiary care. But he also has his footprint in the primary care setting, and he's using
Okay.
technology platform to enable the continuum of care, where patients and their families actually move through that and come to Narayan Health only when they need it. What he's doing is he's creating more capacity in his tertiary care institutions for patients who are really, really sick, who really need it, so they don't waste their resources coming to Narayan Health's tertiary care system when they don't need to. And if they can be caught early on, the care can be delivered. The advantage is this. I mean, you, of course, there is a margin to be made in this primary care that they're providing, because they also have an insurance program that covers these patients. So there's a whole economics around it. But also, these patients are now part of your system. If
Yeah.
the disease actually progresses, they now have a captive patient population that will come to them because there's a trust, there's a confidence, there's a relationship that's been built, and the outcomes are going to be
Mhm.
high because you already understand what's this patient's clinical history was, where they came from, what the cultural context was, what the family context was, and all of that. So it's a really brilliant model. Like Kaiser has tried to do that here, but maybe not as effectively as I think they could have. I mean, I'm a Kaiser patient, so I know what they can do, and at some point I
Yeah.
would love to advise them on that. But I think what Dr. Devi Shetty is trying to do is a remarkable way to do it. Um, Even if you cannot build an Narayan Health kind of a system, like of Apollo and others, I think you can. I know Apollo is trying to do something similar. Their approach is slightly different. But even if you just are a tertiary care institution, if you create a network of primary care physicians, primary care clinics, and you engage with them, you train them, you coach them, you nurture them, you will have a similar kind of a benefit of making sure those
Yeah.
patients come to you. And it happens. It happens in specific therapy areas, and honestly, India is well set for that.
Yeah, I think so. Narayana Health follows the perfect hub and spoke model. They have a telemedicine counterpart, they have a primary care counterpart, they have a center where everyone is funneled, right? Uh, but why are you really passionate about addressing global healthcare needs? I mean, what drives you to that? Where do you
Yeah.
see what is your vision?
Yeah. I mean, when you are building a business, you want to go after markets that are biggest, right?
Yeah,
Where your revenue is going to be largest. So
yeah,
if I want to make impact on human lives, where should I go in healthcare? Global health has 5 billion people who don't have meaningful access to care. Global North has between 1 and 3 billion, how you look at it. A maximum 3 billion. And a lot of those are well cared for to a certain extent. There are a lot of underserved even in our own communities, and I do include that in my focus. Actually, the course I teach at Stanford includes underserved communities everywhere, not just in global health settings or global south settings, but also global north settings. Women of color going through postpartum hemorrhage in the US, for example, are part of that. So it's just the market size. I mean, it's the number of people who I can reach, I can impact, I can help is just much, much, much larger, and the need is far more acute. The outcomes that I can see, even with few innovative initiatives can make a huge difference. I mean, Stanford India Biodesign program is a good example. It took 17 years for us to get there, but it's really has seen substantial impact, and I'm very proud of that. So I mean, it's a no-brainer for me to focus on that.
Yeah. And you also had mentioned earlier about the concept of connected care, connected diagnostics. What exactly do you mean by that? What
Yeah.
does it mean, right?
Yeah, so my journey in global health started with India Biodesign. I didn't think it was going to be global health. I thought most of the innovators will train in India will focus on upper income part of the society there, but they focus on needs that seem like global health needs in other global health settings. And then 2010, I became part of a Stanford program focused on global health. And 3 years later, I ended up joining leadership team at Path. And what I saw at Path really opened my eyes. We had 100 plus
Hmm.
technologies that my team was developing. And most of these technologies were taking a long time to get to the patients, even though we were putting a lot of effort to do that pretty successfully. Actually, Path is one of the most successful organizations in that regard. But still, I was bothered by how fast these innovations got to patients. And one specific area bothered me the most: diagnostics. Most of the diagnostic technologies in global health settings, are deployed in a way where the data from that, unless it's done in conjunction with an intervention right then and there, that
Yeah.
data actually gets to the decision makers far too late.
Yeah.
So you could screen or diagnose the patients, but what happens to those patients? It takes a long time for the decision makers to create solution sets for them. And that just bothered me. It just didn't make sense. I mean, you are basically finding problems and you're not able to address right then and there. It just seemed inconceivable and inhumane to me, inhuman to me. And so what I felt was, it would be really useful if we made these diagnostic tools available to the last mile health workers, but made them connected. So
Hmm.
that everybody in the healthcare system who has anything to do with that diagnosis and its treatment, the solution of that disease, is on in the loop, and the solution delivery actually happens in matter of minutes or hours at the most, not
Remote
days and
monitoring.
weeks and months, because you have what is called loss to follow up. So that's where I started feeling very passionate about connected diagnostics, and frankly, the whole field of digital diagnostics has gone in that direction. You saw that with COVID tests and so on. So I think we are going in that direction. We need to do a lot more, but I think we're on the right path.
Yeah, I mean, I would say this is kind of remote monitoring, but also forming some sort of a digital twin of the future where you have some sort of everything, all your parameters are in one file that can be accessed by any healthcare provider. In fact, India is already building their electronic medical records framework, if I'm not wrong or mistaken. There's still so much work to do. There's still so much fragmentation, but I think so we're getting there very soon in the next 10 years, if I'm not wrong. Uh, my question is, when it comes to really all the experiences you've had so far, what is one example that you have witnessed that really changed your perspective forever towards patient care? Like, what impact company have you seen that has done tremendous good job in that?
Yeah, I think I mentioned a number of examples. I mentioned Forest, I mentioned Tricog, I mentioned, of course, Curia, Curia. Cloud Physician, which provides critical care access to the last mile, uh, Tricog. I think all of these companies are, I mean, they inspire me. I think what they've done in these settings. I mean, I'm just mentioning a few,
Yeah.
but there are hundreds of companies in India and Africa and other parts of the world, right here in the US as well, that have done remarkable work of finding these really difficult problems and finding solutions to them and unlocking solutions for people who don't otherwise have access to care. I just, yeah, all of these, they're exemplars actually that inspire me, and I kind of makes me very optimistic about this flipping of the healthcare pyramid that I often talk
Yeah.
about.
Yeah. So what made investors really invest in these companies, provided the outcomes are delayed? Is it a specific group of biotech investors, or they just focus on one particular category, like digital health, or maybe process-driven solution, which has no regulations?
Yeah, I think that's a great question. I think it's the innovators themselves. They were so passionate about it. They were so clear what problem they were solving and how they were going to go about solving it. Like what Forest does, for example, is not just a medical device. They didn't have to
Hmm.
build an AI platform. They didn't have to
Yeah.
partner with Apollo for tertiary care. They didn't have to partner with the state of Andhra Pradesh and other states to provide a population level ophthalmological care solution. They did all of that because they understood the unmet need, and then they found all the pieces that actually solve the problem. And I think that's what probably investors saw. Investors saw these were very passionate individuals, that they had high degree of knowledge about the problem and its solutions, and they had the ability to deliver, and this and the persistence to get to that end point. So that's, I think that's probably what impressed the investors. And of
And
course,
why?
credit to the investors, they saw something that a lot of others didn't. So
Yeah.
they were able to. My hope is that these investors make big money from these
Yeah.
investments. Some
Yeah.
of them are, because we need more investors going into that field.
Then why many companies in the biotech field, it's not very attractive for the 80% of the other investors? Is it because the fruits come in very late, or is it because of regulations, or they have a wrong concept, or they just want returns the next day, you know?
It's a difficult field, right? I mean, I think
Yeah.
it's much easier to invest in the next messaging app, and just one of those goes big and you get your unicorn exit. Whereas healthcare is much more difficult. I think it's not for the faint of the heart. So you find investors that are somewhat savvy about healthcare, understand the challenges, are passionate about it, see the potential opportunity, and see that the problems have still not been solved, and those are the ones. But it's a very specialized field. Not every investor can really understand it.
And how do we really train clinicians in general to really adopt the innovative mindset, to really find the unmet need? I mean, we have how many people training as doctors in the US and India? But what is the thinking change that is required? Okay, that's a problem. For instance, when I was in a pediatric rotation back in med school, I found a problem that babies fail to latch to the breast. So that's one common problem, and that often increases the number of visits that a baby comes to a pediatrician, right?
As a
So that's
father,
one of the
I'm well aware of that problem. Absolutely.
Yeah, and that was one of the problem I noticed. I was Googling, nothing existed. Maybe there were some breastfeeding companies to train breast training. But how should clinicians really find that problem? Okay, because the the startups coming from Stanford Biodesign or startups coming from anywhere, they have a very clear, focused problem, solving a very clear, focused unmet need. Now, me as a doctor, I'm sitting on an EMR all day. I don't really have that patient interaction, right? I feel nurses are interacting with patients more than me.
Yeah. Yeah.
So, how medicine is changing? How do we really find that problem?
Yeah, I
or
think this
unmet
last
need?
question that you just asked, how medicine is changing, is an important one. I think what healthcare actually means, what healthcare is going to look like in the future, the just the field of medicine, it's going to go through a major shift in the next 20 years. What it means to be a doctor is changing. And my mentees at the medical school here at Stanford, and when I meet with them, when I sit down with them, I ask them to think very carefully. I ask them to look at the changes that are taking place in the healthcare system really keenly, because within their careers, within their lifetime, those changes are going to hit them positively or negatively, and they need to be aware of it. So my recommendation to the clinicians, whether they want to be innovators or not, is to understand the full context of the healthcare, to understand that primary objective of healthcare system, of healthcare delivery, of medicine, is to keep people healthy. It's not only to treat them when they are sick. I think that's a very
Mm,
small sliver of their responsibility, and I think unfortunately our economics, our business models have taken us only to that. We have very tunnel vision around sickness, and even within that, we just look at that one thing, one disease, one part of the anatomy, without realizing that a body is a complete body. It interacts with each other. The biochemical pathways that you have, they all connect with each other. And unfortunately, we have lost sight of that. The kind of medicine that we used to practice in Renaissance period, or even prior to that in Ayurveda times in India and so on. It looked at human body in totality, and look at a disease and a net sum of a lot of things, including social determinants of health. And unfortunately, what we have done is we turned our doctors into technicians, which is not a
yeah.
bad thing necessarily, but we have basically made them put blinders on. And I think we need to undo that, and we need to train them to look at a human body in its entirety, and look at the disease and the specialty that you might be at. Look at the disease and focus on that, but understand how it interacts with everything else. So that's number one. Number two, it'll be important for doctors to start to understand, it's you want to do no harm. So obviously you want to deploy therapies that are well proven, that have been taught to you in medical school with 20-30 years of data. But field of medicine is changing rapidly. There's a lots of innovation coming about, and I think it's important for doctors to start to understand, what are those tool sets, and what are the problems that they are seeing that those tools could be applied to. So
Mm,
not being limited by only the tools that have been taught to them when they were in school, but being open to learning new tools, whether it's AI-enabled tools or semiconductor-based technologies or whatever, right? So that's the second piece. And then the third one is to think of themselves as part of a larger community of carers for the community, for the individuals. Thinking about families, thinking about nurses, then the techs, and thinking about engineers who are coming up with solutions for them, right? Thinking about the broader ecosystem and thinking of themselves as part of that. They are the leading edge. They are the tip of the